Hey everybody, for those that don't know me, I am Fran Matera, the nurse educator for emergency and trauma services here at CHO. And today we're going to talk about diabetic ketoacidosis in our pediatric patients. All right, so what is diabetic ketoacidosis? DKA is something that happens with primarily type 1 diabetics. As we know, insulin plays a key role in helping the glucose enter the cell. Without glucose in the cell starts breaking down fat as fuel instead of glucose. The breakdown of fats causes the body to build up acids or ketones, and this will eventually lead to diabetic ketoacidosis if it's left untreated. We also know that insulin plays a key role in moving potassium into the cell as well, because potassium tends to move with glucose. So if there's no insulin to move the glucose into the cell, then potassium is no longer moving either. So with diabetes, this is just a quick review of what we'll see with these patients when they come in. Sometimes they're lethargic. The parent reports that they're sleepier than usual. They have weight loss oftentimes. Their breaths will smell like fruity, a kind of a fruity smell. They often are nauseous, they're vomiting, they're polyuria, polydipsia is what we normally see with these kids. And they also, if they're compromised, they have this Kussmaul breathing, which is rapid and fast breathing, so hyperventilating and very shallow breathing. So how does insulin work? Well, this is a normal cell here. So insulin, when it's produced, opens up this insulin receptor. So this is the insulin receptor. Once the insulin receptor is open, then the glucose channel opens up and glucose can move into the cell. Because glucose is moving into the cell, potassium also moves into the cell. So this is a normal cell, person without diabetes. With type 1 diabetes, you don't have enough insulin, if any insulin, circulating in the blood. So the insulin receptors will work correctly, but because insulin isn't activating the receptor, it's not opening the glucose channel. So glucose cannot move into the cell, potassium can't move into the cell. You get a lot of glucose, hyperglycemia, and you get a lot of potassium, which is hyperkalemia. So you have less glucose and potassium molecules in the cell, more in the extracellular space. Type 2 diabetes, you have lots of insulin in the extracellular space, but the insulin receptors don't work as well. So not as much glucose and potassium will move into the cell. So what do? The patient has a relative dehydration. So we want to replace that IV fluid by putting them on 1.5 times maintenance fluids, and then also give a normal saline bolus over an hour. Now, we want to give that over a longer period of time than we would say for a hypovolemic patient, because we're not only replacing fluids, but we're balancing all of our electrolytes. So our potassium, our sodium, there is a shift of fluid, there's a shift of electrolytes, and we want that to happen slowly. So generally we don't see that a complete correction for 48 to 72 hours. So give your normal saline bolus over a longer period of time than you would for a hypovolemic. Okay, so there's not enough insulin. So glucose is too high, your potassium is too high. So what do? We start an insulin infusion. With insulin, then potassium and glucose will be able to move into the cell, and you will see less of a hyperosmolarity, meaning that there's more molecules out here than there are inside the cell. So the extracellular space is hyperosmolar, which means that fluid from the inside of the cell wants to move out of the cell to balance this relative fluid imbalance. Okay, so DKA criteria. So inclusion would be a glucose of greater than 200 and positive 2+ ketones and an anion gap acidosis, so pH of less than 7.3 and a bicarb of less than 15. We do not include patients below 12 months of age. We want to watch out for cerebral edema, which most likely will appear or be evidenced by an altered mental status, such as just being more sleepy, complaining of a headache, if they're vomiting, And it also, a very late sign would be bradycardia. How do we treat it? In the short term, we want to use mannitol over 20 minutes, and that will very rapidly diurese the patient, whereas 3% saline is a little bit slower, and that's generally what is used for the long term up in the PICU. So that may be a continuous infusion for a while. What we want to avoid in DKA is to bolus IV insulin, especially to pediatrics, because they're hypersensitive to insulin. We don't want to correct the bicarb, because the bicarb is going to be corrected with all of our fluid shifts over time. So again, over 48 to 72 hours. We don't want to bolus IV fluids just for tachycardia alone. So we definitely will do a 10 to 20 milliliter per kilo bolus, but we don't want to treat tachycardia because tachycardia may be for other reasons. So, and we also don't want to drop in corrected sodium by greater than 0.5 to 1 milliequivalents per hour. All right. So when is potassium added to our IV fluids? When DKA is confirmed, then we check our potassium level. Is it normal? So normal would be 3.0 to 5.0. If you have a K that's greater than 5.0, you want to get your EKG, and you want to you don't want to add potassium to your IV fluids because you already have too much potassium in the serum. If your potassium is less than 3 or hypokalemic, again, you want to get your EKG, and you're going to be adding potassium in the form of KCl and K-phos to your IV fluids. So this would both be to your bag of normal saline and for your second dextrose bag. Your glucose goal for these patients is 150 to 300. Now we'll talk a little bit about sodium correction. So sodium deficits are typically 7 to 10 milliequivalents per liter. With DKA, sodium is falsely lowered by a factor of 1.6 milliequivalents per liter for every increase in glucose of 100 milligrams per deciliter. So we need to correct the sodium, which the equation to correct is you just multiply whatever your lab value is for sodium by that factor of 1.6. So your current lab is reported a sodium of 130, you multiply it times 1.6, and your corrected sodium is 138. So you only want to correct your sodium only when it's still low after calculating your corrected sodium. Hyper and hypokalemia, you've picked that up on your ECG. Here is your normal kalemic. This is a normal QRS. Hypokalemia, you're going to get a slightly peaked P wave, a relatively normal QRS, a shallow T wave, an ST depression, a shallow T wave, and a prominent U wave. Now, most of you remember that hyperkalemia, you get that peaked T wave. Now this here is a pretty severe hyperkalemia. If you look over here, you get mild, you get that peak T wave, but generally a pretty normal QRS. With moderate, you start seeing a widening of the QRS and a tinting of your T wave. With severe, you lose that QRS. So you get a very prolonged QRS, you get a very wide depression here, and then a peaked T wave. This is why we want to get an EKG before starting K or taking it out. Okay, so for IV fluids, we want to start normal saline at 1.5 times maintenance. You're going to add D10NS when blood glucose drops below 300. And we'll add potassium in the form of KCl and K-phos when your K level is less than 5. Now, it may not be in that order. So you may start the patient with normal saline because their blood glucose is high, but you find out that they're hypokalemic. So you may need to add potassium before you actually add your glucose. It's not as likely because most patients have at least a mild hyperkalemia if they're in DKA. All right, so we want to calculate our maintenance fluids. I use the 4-2-1 formula. So it's 4 milliliters times the first 10 kilograms that the patient weighs, 2 milliliters times the second 10 kilograms that the patient weighs, and then 1 milliliter after that additional 20 kilograms. So any additional kilograms over 20 kilo, you multiply it times 1. So we have a patient that weighs 40 kilograms. You would do 4 times the first 10, which is 40, 2 times the second 10, that's 20, and then you do 1 times all the additional kilograms over the first 20, which for this patient is actually 20. 40 minus 20 is 20. So a total for 1 times maintenance is 80 milliliters per hour. But our patient needs 1.5 times maintenance. So we would just take that maintenance fluids of 80 and multiply it times 1.5. So 80 times 1.5 is 120 milliliters per hour. That's going to be your total IV fluids, including both bags over the hour. Now we're introducing this rehydration scale. So for calculating this, we're going to look at it. First, we're going to see 1.5 times maintenance via the 2-bag system. So number 1 bag is your normal saline. When your blood glucose is greater than 300, it's just going to be normal saline. It's going to be 100% normal saline, no dextrose containing fluids. Once your blood glucose drops below 300, and for this patient, we're going to say that he has a blood glucose of 265, so he falls into this arena here. It's going to be 75% of your normal saline, 25% of your D10. So you take your maintenance, your 1.5 times maintenance, you multiply the normal saline bag, which by 75% or 0.75 times the 120 is 90. The D10 is 25%, so that's 0.25 times 120, which equals 30 milliliters per hour. So this is what you would set your pumps for. So 90 for your normal saline, D10 would be 30 for a total of 120. Now this is the way we're going to be setting up the IV fluids and your insulin. So this is a dedicated IV for your insulin and your maintenance fluids. We have a bifuse here. On one leg, you have your normal saline. On the other leg, you have your dextrose containing fluids. Now, if you're not starting your dextrose containing fluids yet, I do not want you to connect this to this second leg. So leave it disconnected, ready to go. You prime it, it's ready to go when you need it, but please do not connect it until it's needed. You have your bifuse here. You have your 4-way stopcock here. Insulin going into the 4-way stopcock and then into the patient. So you want to make sure that your stopcock is open to the maintenance fluids, the insulin, and your patient. Be aware that cerebral edema can be caused by either too much fluid given too quickly or lowering the glucose too rapidly. This is why we want to give our IV fluids over a longer period of time, and we don't want to correct our glucose more than 80 to 100 per hour. If you're correcting more than 80 to 100 in 1 hour, you're going to notify the physician. We may be giving either a bolus of D10W or we will be starting the D10NS. So cerebral edema. It doesn't happen very often in DKA cases, but for those that it does happen in, there's a very high morbidity and mortality. It's caused by fluid shifts from the intracellular space to the extracellular space. So here's a patient with DKA, you have all these glucose and potassium molecules out here. It's hyperosmolar. Inside the cell, since the glucose and potassium aren't able to move into the cell, there aren't as many molecules. So fluid wants to balance this by shifting fluid from the intracellular space to the extracellular space. Now, when we rapidly decrease our glucose or there's too much fluid too quickly, then the brain doesn't have time to catch up. So a rapid correction of this hyperosmolarity causes extracellular fluids to move faster than the brain cells are able to take it in. This is what causes cerebral edema. So we're going to take a very quick look at VBGs, and I want you to take a look on your own time so that you can predict what the patient is experiencing in terms of their blood gas. So we want to know before we can kind of go through this, we want to know what pH that's normal. We want to know our normal values for pH, CO2, and bicarb. For ABGs, you want to look at your O2 and your O2 saturations and whether they're correlating. But in the ED, for the most part, we do VBGs. So evaluating abnormal values, these are the normal values. So our pH normally falls 7.35 to 7.45. A pH less than 7.35 is considered acidotic. It's more acid. A value of greater than 7.45 is considered alkalotic. Now I remember PCO2 as being a respiratory component, and it's also an acidic component. So your normal PCO2 is 35 to 45. If your CO2 is less than 35, so there's less CO2 in there, less acid, it's an alkalosis. If your CO2 is greater than 45, more CO2, more acid, it's acidotic. Then we get to HCO3, which is your metabolic component. This is what I consider the base. So normally 22 to 26 is the normal value for bicarb. Anything less than 22, so less bicarb, less base, would be acidotic. Anything greater than 26, a bicarb of greater than 26, more base, more HCO3, alkalosis. Okay, so ways to remember, CO2 is your respiratory component. Remember the acronym ROME, respiratory, opposite, metabolic, equal. So with respiratory alkalosis or acidosis, your pH will say acidosis. Your pH, in acidosis goes down. Well, you'll see that your CO2 or your acid component goes up. So it's always going to be opposite. If pH and CO2 are opposite, it means that it is a CO2 issue or a respiratory component. Now, bicarb and pH move in the same direction. So if you have a decrease in pH, we know that's acidosis. We also see a decrease in our base or our HCO3. So metabolic equal, they both go in the same direction. Respiratory is opposite. Decrease in pH, increase in CO2. How severe is DKA based on pH? So mild is considered greater than 7.2, moderate is 7.1 to 7.2, and severe is less than 7.1. So we're just going to go through a couple of patients. pH 7.35 to 4.5. Our pH in our patient is 7.27, which is less, so we know that's acidosis. Our CO2 is 53, which is more, meaning that we have more CO2 in the serum, more acid, which again is acidosis. So both pH and CO2 are acidotic. So up and down, respiratory is up and down. Our CO2, our bicarb, is normal at this point. So there's no compensation by the body trying to compensate for this acidosis. So what is this? This is a respiratory acidosis. Our second patient is again a patient, whoops, that's 3, we're patient 2. So 7.18 is less than 7.35, that's acidosis. Our CO2, which is our respiratory component, is normal. So we know it's not respiratory. We look at bicarb, which is our base. It is less than 22. We have less base in the serum. So again, that is acidosis. Now with these patients, let's just say, okay, this is metabolic acidosis. This is what we see with DKA. So once this patient is starting to compensate, this is why you start seeing them breathing very quickly and very shallowly. They're trying to blow off CO2 to bring the acid in the blood down by compensating by decreasing the CO2, which again is our respiratory or acid component. All right, so this is just what you're going to be doing over the first 8 hours when the patient arrives. They arrive to triage. We will call them back and put them in a resus room and do everything. We're going to give that 10 to 20 milliliter per kilo bolus. We're going to get our insulin ready to go. Every hour, you're going to do a point of care glucose, or you're going to do it more often if the mental status changes or if there's any change in the patient's condition. You're also going to be doing your neuro checks every hour. So with your point of care, with your vital signs, you're going to be doing your neuro checks, and then your eyes and nose as well. So that's the quick and dirty on DKA. We're going to go through a couple of different lectures for ED and then also for PICU. I like them.